let's go ahead and get started.
Okay.
I'm Corey Meaux, I'm a partner here at Parker and Landry. We do these monthly. We like to now and then get a guest speaker on here or two. This we're joined by Dr. Chad Domangue, who is a neurologist and pain management physician, as well as Matt Davis, who works at Case Experts. I will let to them kind of briefly give a rundown on their work. We'll start with you, Doc.
So board certified neurologist, board certified pain management doctor, licensed in Mississippi and Louisiana. I do at some point want to do some stuff in Mississippi. As you heard, I do travel Lafayette, Monroe to do defense work. I still do plaintiff work as well.
I can hear it twice.
But succinctly, my background, just medical doctor that's done a lot of legal work and the challenges you guys deal with. So just happy to be part of this group and give my expertise and things that I see and issues that I hopefully help address with your clients.
You certainly do. Thank you so much. I just got 122 pages.
I do take my time. I spend right now, I think my average is an hour to an hour and a half with the claimants going through each visit and getting to the details.
With all the backup. I appreciate all that. You
It's
actually like an attorney.
It's actual work that he's putting in.
Yes,
for sure.
exactly.
It's not just putting some information down and then collecting their check. He's putting in work.
Yeah, definitely. That's why I continue to use him.
I appreciate it.
Yes, sir.
All right, Matt, you want to give a little rundown on?
Yeah, so most everybody here, from what I can see on the side, know who I am. I'm Matt Davis with Case Experts. I'm the Vice President, Client Relations. I am a nurse by trade. I did nurse case management for many years and operations here until Brandon took over operations, and I'm now in the client relations. But we are very close and talk a lot and see each other a lot. So anytime y'all need anything, reach out to me. Most of the time I'm pretty quick to get back, but when I'm not, just follow up with me. Probably something happened and I missed it, but I'm happy to help wherever I can. I'll let Corey start us off.
Yeah. So, Doctor, the main thing we do here is Matt and I are going to give you some questions. We know you hate talking to people, and so try to help you talk as little as possible. But basically, first, what I'd like to go through is just generally, if you can kind of explain what are some of the most common traumatic brain injury cases you see. Obviously, in workers' comp, we are always dealing with the spine, but we're starting to see more and more of these TBI cases come about, especially post concussion syndrome, things like that. So if you can just briefly kind of go through what are you seeing with regards to the injury, with regards to what is probably medically necessary to get them back, and about how long do you see those cases taking?
Is that to me or is that to Matt?
To you.
That's
sorry. I'm looking at Matt like, man, come on. I want to hear it. So
no, you're the expert, not me.
Some days. So first thing I think is important for everybody to understand, because the plaintiffs are very good at mixing this. There is a dramatic difference between having a TBI, right, having a brain injury, and having a brain injury that leads to permanent neurological dysfunction, right? And what I see, and guys, please chime in anytime, what I see that the plaintiffs and the plaintiff doctors have done very well is lump all that together, right? So they basically are creating these narratives that mild TBI, mild probable TBI, I hit my head on the back of a headrest, or I slip and fall and I hit my knee and my elbow first, but maybe I hit my head. And then these very minor traumas, no cuts, no bruises, normal imaging, everything else, all of a sudden go from a mild headache to now I need Botox, now I need neuropsychological evaluation, now I need 24-hour attendance and so forth. So, from my end, these conversations are real simple because none of this is founded in medicine, right? So the answer for medical, again, I always say when I'm talking to doctors, when you're doing legal work, forget about all that. Imagine you're back in med school residency and you're talking to another doctor. So eliminate the extraneous factors. There is no evidence whatsoever that these mild traumatic brain injuries lead to these neurological insults for the rest of their life. Even someone with a bad brain injury, right? Bad bleed, bad all, they make improvements with time. They may not go back to normal, But what we see, and Matt, you know, we've had this conversation many times, we see this waxing, waning. Now I got ringing in my ear. Now I need to see Dr. Giannoli. Now I got balance issues. Now I have to have Botox. The Topamax failed. The Elavil failed. You know, they've gotten so fast at this model that literally the records I'm seeing now in LA Health Solutions being the top in terms of, you know, offenders, I'm seeing patients within a 3-month period fail 5 or 6 medicines and advance to interventional Botox and occipital nerves and vestibular balance clinic, DTI. So they've gotten so slick and fast with it that we're seeing, you know, ER records where there's no head trauma or anything. And then all of a sudden, 3 to 6 months in, you're like $100 grand in the medicals, you know? So that's kind of what I'm seeing. But again, from a medical standpoint, none of the literature validates any of this stuff. Quantitative EEGs, this magnet therapy they recommend. So the other thing the plaintiffs do is they take information that is founded in research and they bring it into clinical medicine, right? And there's no basis for that. Insurance companies don't pay for it. And the doctors obviously stand behind and say, well, they need hyperbaric oxygen therapy 2 months into an injury for the following reasons. But again, the following reasons are based on I said so. So those are the things that I would say is it's fast, it's furious, it's not grounded in medicine. But I think we need to do a better job of juries, judges, whoever, how they are really mixing the water, right? They're really muddying the water on us by taking what is a simple bruise. So a mild TBI is no different than a bruise, right? A bruise to the brain. That don't mean for the rest of your life you can't think and do your job. And that's where I don't like, what are they basing this off that every single person that has any level of head injury is problematic for the rest of their life?
So to that point, Dr. Domangue, if we have somebody who has a head injury, for instance, how much does energy of the injury matter? Like how bad it was as far as how hard they hit the head? And then also like, how do you determine between what is considered a mild TBI versus a severe TBI, and who should delineate between that? And then how do you determine what treatment is reasonable with each one? Does that make sense?
Yeah, so I use the Mayo, and you've got these on my reports, the Mayo classification of head injuries. So there's mild probable, there's mild possible, and then there's a moderate. So possible means you say I got a headache. So anybody can have a possible TBI. Probable means you lost consciousness, you maybe got a cut, a bruise or something. And then moderate meaning prolonged period of time, GCS score was low, bleeds, and so forth, right? But that is all within an acute setting. Where the data fails the plaintiffs is even with a moderate severe injury, 70, 80% of these people making full recoveries in 3 months. Mild probable, mild possible, 90+% recovery in 6 weeks, right? And so where the plaintiffs are failing is the literature does not correlate with this prolonged stuff. And then also where they fail in their records, a single static injury shouldn't lead to waxing, waning, involving symptoms. And so when you see my reports many times, when I go through LA Health Solutions and I compare it to their neurologists and everything else, I'm showing all the inconsistencies between the reporting and basically saying this is anatomically impossible, right? You have a static mild injury and shows elevation. But to your point, Matt, the answer is not found within science. The answer is found with Corey and with you guys, because they are just 0 to 60 running with this, not based on this Medicare guideline, not based on this peer reviewed literature. They are just going and going and going. And as you know, this has become one of the biggest problems we're seeing right now.
For sure. Well, and to your point with neurology, to me, I would say neurology and psych are probably your most subjective of the two as far as what I see in comp. And what we see a lot of times is doctors tend to treat subjective complaints more so in, which you expect that in psych because it is such a brain related. But neurology, I feel like if you come back and you got normal EEGs, normal CTs, normal studies, and then we're still seeing a multitude of treatments following that, how do you combat that? How do you say, like, look, this is a mild traumatic brain injury, like you have overextended. Obviously, you got medical treatment guidelines, but you know how these doctors are. A lot of them are just unreasonable to waiver.
So number one, the literature's on your side. Okay. So literature, number one, is on your side. Overwhelming literature is everything I described, number one. Number two, this is where the value of the record review comes in. And as you know, when you guys hire me, I want everything, OBGYN, primary care, everything, because if they're saying all this stuff to LA Health Solutions, they should be saying all this stuff to every single provider they're seeing. Okay, so that's number two. I want to show the inconsistencies. Number three, I always look for every other reason to have headaches: obstructive sleep apnea, medication side effects, pre-existing history, deviated septum, right? Going through the records and say every 60-year-old has some level of imbalance, right? So looking for the horses instead of the zebra. But the one thing I think we don't do a good enough job on, especially in these type of cases, because of what you just said, we got to get more surveillance on these people. Because at the end of the day, the subjective stuff is the subjective stuff. I can show inconsistencies, I can quote literature, I can quote whatever, but the real thing Corey would love to have in court is they're saying all this stuff, all this stuff, all this stuff, and he's got 6 hours of video of them playing golf and fishing and hunting. So unfortunately, that's it, man, because at the end of the day, you hit the nail on the head. It's literally what they're telling someone. So you got to get them inconsistent. You got to get them lying. You got to get them. And we even need to get to the point where if we're going to do surveillance, we need to be strategic into how we want to do it as they're going into their doctor visits, because we want to show a jury and a judge, I get they're saying this. Number one, nothing in the literature supports it. Here's all the inconsistencies. But number three, here it is in black and white. It's not real other than when they go to these doctor visits.
Right. And I would, if I was sitting in an in-person thing right now, say on a show of hands, how many of you have had issues finding a neurology specialist in the state of Louisiana? And every single person in here would probably raise their hand. So to that point, what's frustrating from our standpoint, you have trouble finding neurology. And then you've got people that are in treatment with neurology that quite honestly should have resolved months and years ago. So we're bogging down the system of neurologists and the treatment of neurology. And we have people out 6-8 months trying to get to neurology. We're instead treating with internal medicine. So not only do we have the fact that you're over treating a mild concussion, basically, as it were a moderate, bleed, and then we're bogging down the system. So you're negatively affecting people that really require the treatment, because we got people that are mild injuries or need to be released that are getting it. So
yeah, and it's a problem. Questions should come up is why we're seeing all this Botox, right? So just to give you a little state of the union in medicine. So this year alone, just to tell you how bad things have come, we're kind of filling the post-COVID medical dollar, right? The medical dollar got stretched too far. So I took a 30% pay cut for Medicare this year, and Blue Cross Blue Shield no longer pays for bilateral procedures. So that's a 50% pay cut on about 30% of my procedures. Long story short, we deal with inflation just like everybody else, rent, salaries. So medicine is having a big squeeze, right? So you guys, because you pay 90% of charges, you are picking up that gap between the insurance. And so
yes,
for a neurologist, we don't have injections, stimulator surgery. So the only real procedures a neurologist does is EEGs, Botox, trigger point injections, occipital nerve blocks, and so forth. So what are you seeing in the records now? You're seeing more EEGs, you're seeing more Botox, you're seeing more occipital nerve blocks, you're seeing more brand name medicines. Have you noticed that? No more generics, right? Everything's Movig, Ubrevely, all this type of stuff. And I don't know all the doctors, but I'm sure a lot of them have some ownership in a pharmacy and there's something involved there. But that's really what you guys are seeing is you as work comp, because you are not giving us the pay cut as everyone else. You're seeing this overutilization because of the monetary value. And for a neurologist treating, nobody wants to treat you because work comp payment on an office visit is no different than Medicare. So why would I see a work comp injury, head injury on a Medicare rate and be motivated to do what you need? That's the problem.
Yeah. Well, we're seeing that big time with the 90% issue in comp. That you're probably the 10th doctor that has brought that up to my attention. Is we're the only ones that are still paying the 90%. It's something that needs to change.
Gotcha.
And until that happens, it's just We're going to keep seeing that. Now, Matt mentioned concussion, Doc, and I have a pointed question I want to ask you because I see a lot where we have a claimant, they go to the ER, they stayed in there, no trauma, no head injury, but there's a severe cervical spine. So there may have been a whiplash, maybe they bumped their head. Then all of a sudden, 2 months later, they're going to LA Health or someone like that, and all of a sudden you've got headaches, blurred vision, dizziness. With regards to post-concussion syndrome, and I don't know if you can even answer this, but is there a time delay where you would be like, no, this can't happen? You can't have had an injury 3 months ago and now all of a sudden 3 months later you're exhibiting symptoms? Or is that just something that happens with sometimes with minor TBIs?
So you can have a little bit of delay, right? So you have any trauma, your sympathetic system, your fight or flight, your adrenaline, your norepinephrine, you're dealing with everything. I'm missing work. I got a lawyer. So you can have a delay, let's say weeks, maybe a month of any symptom, back pain, neck pain, headache. But you're right. For it to be 2 to 3 months out, and now I got ringing in my ear, and now I got this, and Corey, I know you know this because we do a lot of work together. You can almost hear the coaching from the plaintiff attorney in the ear of the claimant, right? I mean, when you look at the records, it screams this overutilization, and they've gotten so sloppy with it. And again, I review so many records. It's rubber stamp after rubber stamp after rubber stamp, and exam findings. Like, I could take 5 or 6 of these records and it's the exact same exam findings, exact same medications, so all of it. So yeah, I mean, some of it, I always try to give people some benefit of the doubt. Some things may take time to evolve and some symptoms may be worse later. But a TBI, again, we as neurologists, we like to make things so dramatic because the brain is so unusual. But a TBI is a bruise to the brain. That's what it is, and I get the NFL and all this kind of stuff. But again, the NFL is multiple head injuries, not one back of the headrest. It's hundreds of head injuries over the years. And when they're quoting this data and they're looking at these studies and the DTIs and all this kind of stuff, they're taking stuff that has no bearing to the clinical applications that they're putting it into, right? And it's just, there's just no logic to any of it.
Yeah. And on that, so getting into our next question, because you kind of wanted to start going there. I see it all the time in your reports. I see it a lot with, the doctor posts. I see it with some orthos. The difference between an organic and an inorganic finding. And you do a good job of saying the subjective complaints grossly outweigh the objective findings. She's giving signs of inorganic findings versus organic. Can you just briefly go into when you say there are inorganic findings here versus organic, what do you mean? Dumb it down for us non-medical people over here.
So as I evolved through my SM rule world, I look at what I said this to the jury in Jennings yesterday. What I do in medical charts is no different than what a CPA does when they come audit your financials, right? So I am looking at medical data points entered by another doctor, no different than a bank talking to another bank. And I'm going through it and I'm using medical literature, I'm using anatomy, physiology, and I'm creating norms within it. So when we talk about non-organic, okay, and it's not always the claimant, these doctors are sloppy. So for example, and again, I throw these guys under the bus a lot because I get a lot of work against them, LA Health Solutions. 3 out of 5 neck pain. You've probably seen this all the time. 3 out of 5 neck strength, okay? All the times. Dr. Jones documents it almost every patient. 3 out of 5 strength means you can only resist gravity. Now say that out loud. If I can only resist gravity, my hand falls with anything that gets on it, okay? So succinctly, 3 out of 5 neck strength means you can't hold your head up, right? And when a doctor documents my whole arm's numb, like, doctor, you're a neurologist. What dermatome, what nerve, what distribution, right? So when you're seeing this whole arm, whole leg, 10 out of 10 pain, but then the gait's normal. How can you have 10 out of 10 back pain and have a normal gait? How can you need to go to vestibular balance therapy and get inner ear surgery with Dr. Giannoli and you're Romberg negative and you're able to tandem gait? So what you're looking for, because again, to Matt's point, everything with a TBI is being driven by what they say, but you got to look at what they say and then calculate it with organic norms, medical literature, and so forth. And then again, you know, I used to tell a jury, if I was to graph the data points of head injury cases, exam findings, headache complaints, yada, 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 the graph would look like this, right? It literally is like a schizophrenic creating data points. And so when I look at those reports and I'm showing non-organic, all these type of things and disconnect, what I'm doing is I am trying for my client to narrow my enemy down to exactly what we all know is going on. This person is injured and can't work ever again because I said so. Because that's literally, guys, at the end of the day, that's what our enemy says. Not based on data, not based on literature, not based on the exams, because the exams are carbon copy. A lot of times the claimants will tell me they're not a B exam. But at the end of the day, I'm going to parade these doctors in the courtroom that are all going to get up there and say, I said so. And at the end of the day, I can't fight that, right? I can't. But my job is to go through every single thing, pain scores, medication usage, literature, and beat up everything I can and say, well, what are we left with? Well, we're left with her saying I can't do it and the doctor saying I said so. Okay?
Yeah.
Right.
That's it.
And then we're stuck. And I want to make a point on something, Dr. Domangue. You mentioned when you get a case in, you want all the records.
Everything.
I want to make a point to that because I can't tell you how many times adjusters are like, "Oh, I'll send you the last 2 years," and I'm like, "This is a 10-year-old claim." I want to know like a book. I want to know every single thing that's occurred to the person, because if I don't know what was tried and failed 8 years ago, what benefit is having those 2 years of records? You as a physician may go and start recommending things and saying, oh, this would help, this would help, this would help. When if you would have had the records from 8 years ago, you'd have known that the medial branch blocks didn't provide benefit, or radio frequency ablations, or whatever. You would know that and be able to comment on that. So I think it's important to point that out, that how important it is. If you're doing an MSA, give them the last 2 years. That's fine. That's all you need. But if you have a doctor doing an SMO, I think as many records as you can possibly give them is best. So
yeah, if you read my records, first question I ask when I go in to claim it, do you have a primary care doctor? Number one. And did you have insurance in place? Because a lot of time plaintiffs will say, oh, they had no complaints before. Well, they had no insurance, bud. They never went to a doctor, okay?
that's a good point.
So two examples of your point. So I got a CRPS case with a client, and she had a surgery that the treating doctor didn't know about. I got the client to pull the nursing records from the surgery to see where the IVs were placed. It's a big thing, right? Because if you're claiming CRPS, right? The case yesterday in Jennings, this lady's claiming CRPS of her arm, okay? So as I'm going through the records, what I find in one of the records, they take her blood pressure. And guess which arm they did the blood pressure on? The nurse noted blood pressure right arm. The doctor didn't see it. So the doctor puts allodynia on his exam, but in the same record, the blood pressure, so I lifted up the blood pressure cuff to the jury and I inflated it. And I said, how could you have allodynia and tolerate this? And you can't. So
Right.
To your point, you just don't know. You don't know what they're going to tell an OBGYN. One I'm looking at for next week, she's claiming back pain with no pre-existing history. Well, one thing I saw within the records, she just had breast reduction surgery. Well, a lot of times girls get that for back pain. Again, I don't have the records yet, but it gives me something that I can say, hey, look, guys, this is a reason why this person has it. And these claimants lie, they're hiding stuff. But I always say, Matt, when I look at records, my first job is how do I get to the starting line? I want to know this person really well before this happened.
Same.
What's your work history? How often, blah, blah, blah. Any motor vehicle accident, any traumas, talk to me about your hypertension. Do you take your meds? Talk to me. I mean, I go through every single thing because I want to know exactly what you're looking for. There's no way at 265 pounds at 55 years of age, this is the first time you had back pain. I'm sorry. I'm just not buying it.
Right. And I'm curious on that, Corey. What does that type of mindset do when you get in front of a judge and a judge says, look, he's only seen this person one time? Well, that may be the case, but he's reviewed every record from 15 years ago to now. What does that do to a judge? Does that give it more credence?
From a legal standpoint, that's what we're constantly fighting, right? The treating physicians You know, we fight that case. We've gone through different potential strategies, you know, allowing them that initial visit, then immediately after I'm going to deny based on causation, go get my SMO, because guess what? Now my SMO and physician have both seen that patient one time. So you don't have a treating physician presumption anymore. Now, I will say with regards to, you know, Dr. Domangue's reports, it bears a lot more weight when I'm giving a 90-page SMO report to a judge versus a 5-page SMO. So I think that definitely helps. And the fact that I can say, you know, judge, look at the amount of records and the amount of time he spent combing through this stuff. And so that definitely does help. The problem is basically the point of the SMO these days is to go and try to get that IME, because we've got to have the tiebreaker because of the treating physician presumption. So I think it helps whenever you provide the SMO with all of the necessary records. I don't want the claimant's attorney to come back and say, well, your SMO didn't have this, 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 this. I would much rather have that to go after the treating doctor. I've done that multiple times. You know, doctor, whenever you gave this causation argument, did you have these records? You know, well, after reviewing this and the fact that that primary care physician stated she's been having neck pain for 2.5 years, would it change your causation opinion? And sometimes it does, sometimes it doesn't. Obviously, you know, certain doctors, they're going to stick with their guns. But I think for sure, obviously, having your SMO have all of the records is definitely a starting point to fight that treating physician presumption. We're never, in the current state of things, unless something changes, we're never going to be above it, just because of the way the statute's written, the way the case law is written. But it definitely is a more ammunition for us to use. Right. So I think it's definitely important. But
yeah, Keith Landry, I have to give Keith credit for this. He's the one that helped me do this. I think me sitting with them and going through each and every visit and reconciling pain scores. So I think that gives me more credibility as a SMO doctor, because unlike the treating doctors, they don't go through each and every physical therapy record, chiropractor. So, you know, like you said, I'll judge. I've examined her once, but unlike the rest of these doctors, I did take the time and ask about her hypertension. I did take the time and ask about how is her thyroid disease different from the dizziness she's feeling now, right? So I think you're right. I think at best it evens the playing field. It won't take me above them. But unlike them, at least I can say, well, I didn't examine her as much as you, but look at what I did that you didn't. I sat with that person for an hour going through each and every single visit, reconciling. So then I say non-organic, or I say these things that they get upset about, I can say, well, time out. I sat down with your client and asked specifically about that finding on that day, and they either agree with it or they didn't, right? So, I mean, right. I think that, you know, I think that changed a lot of my reports once I started doing that.
Yeah. Well, and with that, with organic and inorganic, how do you get from a judgment of just organic and inorganic findings to straight up malingering? How do you, obviously, I know there's a lot that goes into it, but what basically triggers that in your mind? Like, all right, this is all financial gain. This is all malingering. How do you judge that, obviously, with the records, but really in your examination of the claim?
So the M word is one you got to walk around, right? Malingering is one of those ones that it's a strong word. And if you know, when I was younger and doing these reports, I threw it out a little more than I should have. It's something that, you know, changes the complexity of the report. So where I usually say now, when I see inorganic findings, evolution, I just make it very clean. This doesn't make sense. And then what I usually do is say this falls into one of the two things, malingering or somatization. And I think it makes me a little cleaner, because people that have somatization disorder don't know. They're not doing it on purpose. That's the only thing that separates malingering from somatization. Malingerers know they're doing it. They're doing it for money, for attention, whatever. Whereas someone with somatization disorder, you know, they're involved in a lawsuit, they're not at their job, their lawyers telling them, you got to give people the benefit of the doubt, right? Sometimes these are good people that are just put into a bad situation, you know? Mm-hmm. And so somatization is a manifestation of all those psychological symptoms, right? But if you really want to go after malingering, you need a neurologist and you need a psychologist to agree with me, because there are specific psychological tests that I don't do that have to be checked for malingering. So That would be checkbox number 1, me ruling out the organic stuff, checkbox 2 being the psychologist, and then checkbox 3 is on the legal side, which is you taking all that data from the records and everything else, and you looking at a judge and saying, here are Blue Cross Blue Shield guidelines, here are Medicare guidelines, here's Dr. Domangue's anatomical pictures he sent us, here's the medical articles, and then you put it all in together, and then you add the psych where the claimant failed X number of tests from malingering side, and then you fight for it. But as you know, malingering is a very tough one because we live in a state and we have a system where everyone is presumed to be injured and terrible, you know, unless we overwhelmingly prove it's not. So it's not easy. I mean, that's just it in a nutshell. It's not.
Yeah, that makes sense. Also, for everyone here, I forgot to mention at the beginning, if y'all do have any questions for Dr. Domangue, in addition to what Matt and I are asking him, feel free to put it in the chat. I know y'all may have seen something in your cases that you want Dr. Chad to go ahead and go into depth about, but from a pure, I guess, getting away from TBI and getting into more, we see the spine the most. So can you go into, Doc, kind of some of the most common injuries versus red flags? And what I mean by that is kind of taking what we've already gone through and going from, you get an SMO from me and you're like, Corey, this person's legit injured, versus the vast majority of what we see, you know, coming from LA Health and this and that, for the spine, cervical all the way down to lumbar. And can you kind of go into the differences of what you've seen over the past few years of when you are, this is a legit accident, they need this surgery, versus no, and kind of just take us through what you're seeing more and more?
Yeah, so I would say, you know, simple answer, what I'm seeing more and more, I'm seeing more surgeries. I mean, I think the fusion rate's going up. I mean, that case yesterday, Matt, you're going to love this. They put a stimulator. You know what the life care plan said the stimulator costs? $375,000. A small house.
Oh my gosh.
Yeah, actually probably a nice house, 2-bedroom house, right? So again, I think part of it is the system we have. People, you know, doctors are getting wise to how favorable the system's for them. But I think the answer I said earlier with the reimbursement going down is why you're seeing that. So the biggest stuff that I see spine is the rhizotomy, epidural, stimulator, surgery stuff, right? And so where I beat up the records is I try to figure out what is the decision making that is driving the care. And Corey, you and I had this conversation. This is where it's important for me to work with Matt and work with Corey, because if we're going to go to court, which I always assume we are, right? If we don't, great. But if we're going to go to court, we need to corner that doctor into committing to us. What are the analytical points that he is using to drive the care? So for example, you see a doctor do bilateral medial branch blocks, 4 levels. Number one, why 4 levels? Why bilateral? Based on what, right? And the answer is going to be, well, I don't know. Okay, well, great. But give me something, right? And then they'll change to doing an epidural. Why? When they do a procedure, what is the pain score before and after? What is the physical exam finding before and after? And again, if we were in a perfect world and the work comp system was behind us, before we did a procedure, doctor, what is the outcome you are expecting? Light duty, sedentary duty? Like, give us, the problem I see with the spine care is no different than the head care. And I ask the claimants this all the time, you see in my report, is it a fair statement, Mr. or Mrs. whoever, that based on the records I reviewed and based on talking to you, there is no end in sight? At no time has your doctor ever discussed with you, if we do X, if we do Y, if we do whatever, we anticipate you going back to this job by whenever. And every single time I ask that question, I get the same answer. That's never been discussed, and I don't know the answer. So as I'm looking at the medial branch blocks, I'm looking at the rhizotomies, then I'm looking at the SI joints, and there's one I'm looking at for next week, where after one visit, he recommended bilateral knee injection, shoulder injection, medial branch blocks, bilateral neck, medial branch blocks in the low back, as well as SI joint injections. One visit. And she just got done with physical therapy the same day, the same visit, with 1 out of 10 pain with normal age-related imaging. So again, if I'm deposing that doctor, like, what is the basis? Give me a Blue Cross Blue Shield guideline, give me a Medicare guideline, give me peer-reviewed literature, because we always poo-poo the guidelines, right? But the guidelines in the insurance world are grounded in science. Any guideline you pull from Blue Cross will quote the studies that they come up. Now, I'm not saying they're perfect, but what happens at work comp is your guidelines are different, and your guidelines are easily twisted a little bit more than Blue Cross Blue Shield. And you also don't have the limitations that other insurance companies have in terms of number of levels, in terms of bilateral versus one side. And so where I'm looking at work comp is like, we are archaic in the way we're paying. We are archaic in terms of these guidelines. And these doctors are doing a completely different treatment regimen and live in a completely different world. It's almost like you guys are my camp or my condo in Miami, right? You guys are my fun time. You guys, I get to come to Miami. I get to hang out. I get to do what I want. I get to do whatever. My kids are not there. You know, that's how doctors treat work comp. It's just a wild west. And it's even worse in plaintiff world where you have no guidelines. If Morris Bart writes a check and you want a 3-level fusion, dude, I saw one yesterday. Medial branch block work, second medial branch block work, doctor on the third one, realized how much money was involved. Let's do a 3-level fusion. Didn't do the rhizotomy. We're just going to skip it. 3-level fusion. Just going to skip it. Why? I don't know. I said so. I came down to Olympus. I put my ambrosia down and I said, I'm going to fix this lady's back. You're welcome. So that's the thing, is you got to figure out a rhyme. You got to figure out a reason. You got to give logic. And you know, Matt, Corey, you know this. There's never logic. There's never a rhyme. Pain scores don't change. Exam findings don't change. Radiculopathy one day, medial branch block the second. And at the end, you guys are stuck with hundreds of $1,000s of a bill and a claimant that can't work. I mean, if you're doing work comp, it's not Medicare. It's not Blue Cross. You should absolutely, by the state of Louisiana, be required after every visit to make some type of comment about your long-term plan. How is that possible?
Right.
How is that? How do we allow that in this state? How is that possible? The whole purpose of work comp medical treatment is to get someone back to work. Dude, I see people getting their blood pressure medicine paid for by work comp. Their protonics for their stomach is getting paid for by work comp. They're just abusing it as if it's Medicare. So again, when we're deposing these doctors, and I know, you know, Corey, we do trial prep sometimes, it's always about getting that doctor to commit his hand as to what he is using. And then once he does that, then we can huddle back up and I can give you articles and, you know what I'm saying? And now we got him committed. If we have to go to court, say, well, look, Your Honor, deposition, he said right here, I'm 100% doing this based on what she tells me. Okay, let's talk about what she tells me. Chiropractor records, PT records, surveillance, you know what I'm saying? Like, then we don't say bad doctors, we just say, man, doc, she's lying to you. So those are the kind of things that I look for, but you know, it's more egregious than that. You know, exam findings, all whole arm numb, weakness, all this kind of stuff. But yet they're going on vacation, they're cutting grass, they're doing all these kind of things. But there's just the work comp guidelines need some update for sure. But it's just, I don't know, man. I don't know what else to say other than just the egregiousness that is happening and just the lack of logic or any guidelines being followed.
So you made a point, Dr. Domangue, about the when people, there's no end in sight. So something that we do with our nurses, and we don't require this, but we highly, strongly encourage it. It's just a lot of times some adjusters don't want you to do it, some do. I highly, highly suggest this to occur. Is if you get a request for surgery and there's a request and you approve it, or you're going to approve it, we highly recommend that you go in with a physician and talk about
absolutely
how are you going to do the surgery? When are you going to do it? What's the recovery afterwards? What do you expect regarding MMI? What do you expect regarding return to work? Like, what type of medications are they going to require after? What type of PT? Like occupational therapy? What type of DME at home? So basically what we view it as is you're painting that physician into a corner and you're making him or her tell you what their expectations are from the surgery that they're recommending. And then when that surgery occurs and you don't get the expectations that they verbalize to you, then you come back and say, look, doc, you're the one that told me all this. You're the one that said they'd be released at 6 months in MMI. What'd you do wrong? Which, I mean, I wouldn't say it that way, but no, that's kind of what you're pushing is, what did you not do to comply with what you thought was going to occur from this surgery being done? So I think it's important that you don't just blindly approve something with a physician surgery wise and not get their ideas and their opinions on things that what will happen post surgery and during the recovery phase. So does it help all the time? Not always, but does it help a lot of the time? Yes, it does. It allows us to get back in front of the physician, and when they start hearing words from themselves, a form that they signed and said would occur, they're like, oh, maybe I should stick to what my original plan was. Now, it doesn't always work, but it does a lot of times. So
yeah, one of my clients, man, I think we talked about this earlier. I started doing peer-to-peer reviews to the doctor. And it's different when a doctor's looking at me versus a nurse, right?
right.
And I do the same thing. And I say, doctor, a lot of these guys I know in the community, I say, look, man, I'm not here to beat you up. I'm not here, whatever. I said, but my client and me need to understand why someone with a knee injury can't push paper. I just need to understand that. And I've gotten 2 of them to come off their stance because they can't look me in the eye and answer that question. But again, maybe there's an answer, but just like you said, if I can get a bait stamp of something, of something, and again, we're not gods, right? Not everybody's going to have a good outcome. But if I can get a doctor-to-doctor conversation with Chad, I'm trying to do blah, 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 blah. If it doesn't happen, at least I can go back to Corey and say, hey, look, man, we got this doctor saying we were going to do these following things, and now they're claiming a head injury. Now they're claiming blah, 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 blah. And that's exactly one of these cases is very similar. She went from a knee injury. Now she's saying she got a head injury and all this kind of stuff. But the nice thing about this case is I got a bait stamp of when I talked to that doctor before things got into left field. And he agreed to let her go back to work. And now he's doing an about face. But at least, like you said, I got something before things happen that, Corey can use and say, look, guys, we are trying to be proactive to get somebody better. But if you're going to constantly change the narrative and our doctor's talking peer to peer, and you're going to change what you tell the doctor to his face as soon as you go back and talk to the plaintiff attorney, how are we supposed to do anything with that? How is my expert supposed to stay unbiased and medically analytical when you're doing this kind of, horse stuff? It doesn't make sense.
Yeah, and I think it also helps with me. It helps with me in court to challenge the credibility of that treating physician.
Yeah.
We always hear it from the side. They're always like, oh, well, every SMO you get, they're going to say return to work, full duty, this and this. But I turn it back around them all the time. I say your treating physicians do the same thing on the opposite side. So don't come to me and say your SMO is going to return back to work. Your doctor's going to keep them off of work for 2 years. So it helps me then point that to the judge. Like, look, doc, we had Dr. Domangue do a peer-to-peer, and this is what they said a year and a half ago and where their goals were. And now this is where we are. That's why it's not causally related. So I think it does help. Good idea. Now, before we get back into some more causation stuff, Nathan is asking Doc, and I can't remember. I do know you travel all over the state for SMOs. Can you go through real quick what cities you travel to?
So I go
Lafayette.
So I do Lafayette at least once every other month. Just depends on the volume, right? I'll go Lafayette every month if I have to. I'll be in Monroe the end of September, and I'm willing to go to Monroe probably every other month, depending if Matt lets me sleep at his house, maybe every month. But no, look, guys.
I got a nice couch for you.
Yeah, he's got a nice couch. I'm willing to travel. I am, but you got to understand, I still got to pay rent here. I still got staff, so it's got to be worth my time. I had one client ask me to go to Metairie, and I'll go to Metairie if I need to. And again, I have the Mississippi state license. I'm willing to go to Mississippi. So those things are not an issue for us. The only issue is whether or not it's enough volume to justify the day. But no, look, I'm willing to play ball. It's not a problem for my end.
Is it when you're going to these cities, you're talking to different, is it chiropractors, is it physical therapists? Who are you talking to use their office space?
So I use a chiropractor's office space in Lafayette. He was a friend of a friend. And then in Monroe, I think we used, it's one of the hotels next to the Drew Brees place, Matt,
Hilton
arcade.
Garden.
Yeah. So I just use a conference room. I just rent out the conference room and, see them and examine them. But if I go, if I start making a more regular appearance, then I probably would look at, getting a set space. But, again, this idea that this attorney was making about where I examine them matters, that's got nothing to do with nothing. I mean, as long as I'm seeing them and touching them, that's all that matters.
Okay. Well, yeah, I just wanted to, Nathan had asked that in the chat, so I wanted to confirm that. So we're kind of getting to where we're wrapping up, Doc. As you know, at SMOs, I think in basically every single one I've used you for, my main concern is causation. We're getting to where we've got 2-3 years, we've got, a prior MRI, they've gone to a chiropractor, they've done prior injections, they're working, and then all of a sudden they have their accident, and there's a question of, is this an exacerbation, an aggravation? Have they returned to baseline? When you are, and we go to court all the time, and the judges, there's a difference between legal causation and medical causation. However, from whenever you're looking at medical causation and you're making a determination of did the accident do anything to exacerbate it? Or B, if it did exacerbate it, have they returned to baseline? What are you looking for in both the records and the examination to make that opinion for your SMO report?
So several things we talked about already. So number one, back when Matt said, I got to get to the starting line, right? I need to know this person. I'll be honest with you, Matt, I would even like, as we evolve this service line, I would even like the ability to talk to their supervisor, to talk, what I'm saying? Like for me as a medical doctor, and look, I'm not a lawyer, I'm not deposing people, but when you're claiming subjective complaints, I need to have an understanding of your life and who you were before the injury happened. Because if not, I have no baseline. And I think back to your point earlier, Corey, that gives me so much more credibility than a treating doctor, because treating doctor takes everything for face value, 10 out of 10, everything. And they don't do any due diligence to get to the baseline. So number one, it's getting to the baseline. And then once I get the baseline, then I look at the objective evidence being generated by the plaintiff doctor, MRI findings, EMG findings, EEG findings, and taking all that objective data and then looking at it and seeing how much of it is what they say. How much of these abnormal MRIs are truly abnormal versus just bone spurs and things, So then going through the objective data, and then after that, seeing the subjective complaints and the correlation of it versus other things that could be causing it, right? So other symptoms that they're having, UTIs, menstrual cycle bleeds, other things that could be causing back pain that they're not reporting to the doctor. So that's kind of what I'm looking at in terms of a causation, and obviously, how big of an impact this was, if there are any videos of the accidents and so forth. But I think, the real gist of where you're at, Corey, and I think, for the listeners, the viewers here to take from what you said is the reason why what Matt was saying is so important. Getting the nurse's notes, getting primary care doctor records, and I know I wear some of y'all out with all the stuff I asked for, but this is exactly why. Because if Corey's going to go to a judge, a jury, and say, man, I got to figure out causation, and the first record I look at is the day of the accident and a 65-year-old with 20 medical comorbidities, I can't look at Corey, my client, and say, man, causation is not there. Because then records can come from somewhere else and, everything I thought was wrong. So I think that's the big thing on causation, is getting to the start line, and then all the things we discussed after in terms of, objective findings, things correlating, waxing and waning, non-organic versus organic, and, all those type of things. Matt, what's your thoughts?
I agree 100%. I think it's important to, it's frustrating when you get just bits and pieces of a claim and then are expected to offer a great service with bits and pieces of a claim. And I think the more you know about a patient, the more you close that gap between treating and SMO. The less you know, the less records you have, the less knowledge you have about that injured worker, you just drop your credibility more and more because, well, you're not the treating physician. Well, you don't know this patient as well as the treating does. But as you obtain more information and review more information and have more and more in your report, I mean, I have found that on yours, you know more about these patients than the treating knows.
That's right.
Because of how detailed it is. So
right.
Technically, when you get to from Corey's standpoint, there's probably instances where Corey could be like, all right, treating doc, did you know this? And he'd probably be like, oh, I didn't know that. Because you're looking at a lot more information than they do. And let's be clear that, and I think you would agree with this, Dr. Domangue, is that these guys, a lot of them are seeing them for 2-3 minutes at a time and then going to the next visit
or the next
clinic, or they're not the PA and the nurse practitioner. So to assume that these physicians, just because they're the treating, have more knowledge of the injured worker is is short-sighted, honestly. I mean, we've all been to physicians and had our 15-minute charge, and we got what, 2 minutes, or it was with the PA or the nurse practitioner. Honestly, it's a necessary evil for y'all to make money, to have to roll them through and in and out. But anyways, no, I agree with you. I think the more information, the better. Coming from a nurse case management standpoint, someone that did a lot of catastrophic claims and a lot of old dog claims that needed a lot of cleanup. I loved getting all the records, and then I basically put them in a timeline and made them read like a book. I want to know from start to finish, and I want to know every single thing about that person. And then I want to recommend from my nursing standpoint what should be done. So, and I can imagine that's what you feel like from the physician standpoint.
Yeah, I mean, Corey, you'll love this. When I was in court yesterday, I looked at the jury. I said, there's 5 doctors involved in this case, 4 treating, I'm the 5th, right? And y'all heard them before you heard me. I said, of everybody involved, tell me if I'm wrong. I'm the only one to look at all the records, and I was the only one to provide any medical literature.
Mm-hmm.
That's it. And I was the only one, on top of that, the third thing, I was the only one to sit with the mom and the daughter and go through each record and ask questions. You can't argue that. Right. To me, that takes away the veil of, he's just an SMO doctor. Because just like you said, now I think the jury's looking at me and saying, man, this is the only doctor that's credible. This is the only doctor that actually took the time to look for other reasons. Because you see this all the time. When you have an injury, the treating doctors are myopic to the complaints related to the MVA only. They come 100%. In, blood pressure's 200 over 180, and they don't even mention it. And the guy's got headaches. Dude, send him to the ER. I don't care if he hit his headrest 5 months ago. Why is he not in the ER? And they conveniently gloss over their obesity or their thyroid disease or all these things that are actively going on. And they're just myopically, everything's from the slip and fall at Walmart 6 years ago.
And you talk about that myopically looking at it. We talk about all the time how medicine has become more and more compartmentalized. I mean, you remember what, 20 years ago, you had general orthos everywhere. Yeah. Nowadays, it's ortho hand, ortho knee, ortho shoulder, ortho foot. Like everybody is just spreading down this little tree and becoming more and more and more narrowed with their treatment. And the reality is the right hand a lot of times doesn't know what the left hand's doing.
No. I see even in the same group, but the chiro and the therapist and the neurologist, they're all in the same group, and they're all the individual records are different, and they're in the same EMR. It's like they're not even looking at each other's records.
I think the big issue is, you said it, Matt. A lot of times we're seeing, 4 visits with the nurse practitioner or the PA, and then on that 5th visit, the doc finally sees them. I mean, I know from personal experience, my primary care physician, I've never even met him. I've seen the nurse practitioner and the PA now. The good thing is that means there's really nothing wrong for my yearly physical, but I have never met my treating doctor. I've been going to him for 5 years, never even saw him.
Right.
But see that all the time where the first visit I'll see Dr. Marco Rodriguez. Then 4 visits in a row, I'm seeing nurse practitioner and Dr. Rodriguez just saying, yes, I reviewed this and it's accurate. Well, doctor, can you speak to that? How in depth do you think those doctors are looking at the nurse practitioner? I know you obviously may practice different than them, but as a whole in the medical community, how much are y'all really, like, once you trust your nurse practitioner or trust your PA, how much are you really diving into their examination, their notes that they put for that visit?
Yeah, so a couple of things, as we evolved through the SMO, I'm obviously paying neurology, right? But I've gotten to the point now where even if you got an ankle injury, I can look at records and see inconsistencies, even if it's outside of my field of medicine, right? Because really the formula they use doesn't matter what the injury is, whether it's head injury, knee, back, heart, whatever. It's a very similar formula. So, but to your point about the mid-levels, what a mid-level is doing, I got 2 of them. A mid-level is looking to check boxes and to get home. That's what they're looking. They're looking to refill your meds. They're looking to schedule an injection. They're looking to please their doctor. They're not looking to talk about your heart, your lungs, and other medical problems. They're not really understanding the legal game that much. They're literally looking to follow on what the doctor said the visit before and just move it along, right? They're not looking to change the course. They're not looking to look for other causes. And, a lot of times, and y'all seen on my report, there was one in Lafayette where the claimant told me the first time I met that doctor is when he cut on my back that day. It's the first time I met him, first time I saw him. And, it's to your point, But the problem is with the electronic records, you don't always know. And this is a problem, right? They'll send someone the video, tape record me and my conversation on SMO or blah, 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 blah. Why can we not have somebody present on all these visits to figure out what's going on? You're asking for millions of dollars, man.
Right.
I agree.
It's a problem. Why can't we look at all this stuff and video it or record it or whatever? Like, you can video me all you want. I don't care. I'm not lying. I'm not hiding anything, but I go ahead.
Well, we've got about 2 minutes left before I don't know if it's going to automatically shut me off or what, but it just gave me a prompt saying if you have 5 minutes left in your meeting. But Doc, just to close things out, I mean, are there any things we've left out? Are there anything you kind of just want to go ahead and shout out to the world?
Yeah, I mean, just the things we talked about. Again, if you ever need issues like looking at reports, I mean, again, we've gotten very good at no matter who it is. And, even if you're looking for SMOs outside of my specialty, I think if we create the product in terms of looking at the records and creating the linear points of data, it's always nice to hand it to a doctor in a different specialty and say, hey, look, I'm not trying to tell you what to say, but here's the data points. Because the problem with a lot of SMO doctors that do it on the side is they don't treat it the way we're talking about it, right? They kind of just rubber stamp it in black and white. And what I don't want, and I know Corey knows this, you don't want your two SMO doctors not on the same page. You don't want your pain guy go up there and then the spine guy come behind. Well, maybe Chad's right, but not
Right.
so. So I think it's important for all of us to be on the same page, right? To make sure everybody's looking at the same data points. Financial analysis, if you guys need that, I mean, that's a big part of what we do as well. But I think it's, to me, the catch of what we're talking about is the lawyer, the case manager, the doctor, the adjuster. We are against such a system that I always tell people, if we're playing football, when they shoot the gun, we're down 20-0 because of the laws, the judges, we are down 20-0. So we cannot, when I say we, Corey cannot walk in to fight this with Matt having different records than me and me, it just doesn't work. So we have to be buttoned up. We cannot make mistakes because the mistakes are built into the system for us. So that's all I would add. It's just, it's not about neurology. It's not about pain. This is medical analysis. This is medical literature. And what y'all need at the end of the day, y'all need someone to speak Spanglish and to extrapolate medical data into data points that gives you all the things you need to do your job and to put us on the same page.
I agree. All right. Well, appreciate your time, doctor. I know you're busy, especially on Fridays.
Got kids, man. Bunch of kids this weekend.
Next time, Transformers, you can show everyone your big hat collection. I know you've got them.
Absolutely.
Really appreciate. As always, I appreciate you as well. If anyone has questions, follow-ups, you can email me, you can email Matt. We'll get them to Dr. Domangue and we'll get you an answer. But we appreciate everyone showing up during your lunch hour, and everyone enjoy and have a good weekend.